home of medicine podcast with me, Dr. a.Burbridge. I'm a consultant in acute and general medicine.
Hi, I'm Ben Lovell. I'm also a consultant in acute and general medicine. Nice to see you, Amy. I haven't seen you for a while.
I know. So I've been taking a bit of time off work, I guess, to regroup. But I'm here today and raring to go with a case for you, Ben.
I'm ready.
So this is a case that I wasn't the first doctor to see this individual. I was about the second or the third person to see the patient. It was on a Sunday. It was about 5 o'clock in the afternoon. And I'd asked one of the resident doctors to go and take history and examine the patient. And before I went in to see him on the ward round, he said to me, I'm a little bit concerned about this patient. I was in there for quite a long time and I'm still not entirely sure what's going on, but I do think there's something that we need to get to the bottom of. And I don't know about you, but when a doctor pre-warns me of a case, I'm not sure whether I think that's a good thing or a bad thing, or whether that changes my perception of when I go in to see the patient. But it was the end of a long weekend and I was like, it'll be absolutely fine. So go in. So I'm just going to tell you a little bit more than about the actual case. So this is a 35-year-old man who has no past medical history of note and was seen with his wife. He was lying in bed as I approached and his wife was sitting next to him holding his hand. And he looked well. His wife was very chatty and we started to have a conversation. He said he'd been unwell for a few weeks. And by unwell, he meant a bit fluey, runny nose, a bit of a cough. And then he started to feel a little bit better. Then one day prior to admission, he became unwell and very weak and went to bed. This was around 4 o'clock in the afternoon. He woke at around 9 p.m. He felt hungry, went downstairs, ate some food. He felt very faint and his wife describes that he passed out on the floor. He says he doesn't really remember passing out, but just before his vision had gone blurry. And that was what he remembers. His wife says his eyes rolled in his head and he had jerky arm movements on both sides. At this point, he was on the floor. She says she then started CPR for 15 minutes. And the patient says that he was aware of what was happening, but she was doing CPR for 15 minutes. So at this point, I said, can I just clarify what you mean by CPR? Because CPR normally happens when your heart stops and breathing stops. There is no pulse. An individual is in effect dead, and therefore we need to resuscitate. And she said, yes. And I resuscitated him for 50 minutes doing chest compressions. And I was like, okay, it's quite unusual because the patient said he was aware throughout. And I couldn't really get to grips what was happening. And I tried to delve a little bit deeper, saying, did you check for a pulse? And she said there was no pulse. Did you check there was breathing? There was no breathing. And I said, and the patient said, but he could feel the CPR happening and he was aware of the surroundings. So I didn't really understand what was going on, but the wife called 999 when he came back round. And the ambulance crew came to see him and said he doesn't need to go to hospital. So I thought, well, that's unusual because if he'd had a cardiac arrest that needed 15 minutes of CPR, then he would need to be in hospital. I was unable to obtain the ambulance notes, so I wasn't sure what had happened, but he was taken to the emergency department and he was in the waiting room. So there was no concern from the ambulance crew or on triage that this gentleman needed any closer observation. When he was in the emergency department waiting room, he passed out again. He had left arm jerky movements. It lasted around 1 minute. This was observed in the hospital. He had no loss of continence. There was no tongue biting noted. And when he woke up, he said he felt back to normal, just hungry again. I'm going to leave it there.
That was quite a roller coaster.
Absolutely.
I had quite a face journey there, which didn't come over via the media of podcast. Where to begin? Right, all the way from basics. When patients have a collapse and they have what we call a T-lock, transient loss of consciousness, I always frame it to patients as what we're trying to work out here, sir or madam or other, is that whether this is a problem with your head or your heart, i.e., does something go awry in the brain or something with the heart rhythm? or output, for example, transient hypotension. Now, when I mean something in the head, was this epileptic in origin, or heart? Was it an arrhythmia, a bradyarrhythmia, for example, which caused slowing of the heart, decreased cardiac output, and dropped the blood pressures to the level where he was not perfusing his brain and lost consciousness? Now, looking at his particular story and trying to work it all out, what evidence have we got this could be epileptic? Collapsed, jerky arm movements, but you can get some jerking of the limbs with neurocardiogenic syncope. If you've ever seen someone or seen videos of someone who has a faint, a vasovagal syncope, they actually do have sometimes a few little jerking movements of the arm as they go down. So that in itself is not diagnostic of epilepsy. Are you saying 15 or 50 minutes of CPR?
15, 5 minutes.
So the wife was so convinced he died, she did 50 minutes of CPR being very painful and breaking ribs in conscious people, and he didn't push her off and say, get off me or stop. Usually people who have arrhythmogenic collapses, what you used to call Stoke-Adams attacks, it doesn't last for 15 minutes. You wake up pretty quickly and you have your wits about you when you wake up. You classically go very, very pale. Sometimes your heart rate could be so slow as to be undetectable and people think, gosh, they've had a cardiac arrest. But normally you come around pretty quick. And the preserved awareness, that goes more with cardiac, because if you're having a tonic-clonic seizure, then you don't have preserved awareness. So it's still a little bit muddy in sort of chapter 1 of the story, which was what happened in his house. Now, the ambulance got here and even though she had 15 minutes of CPR, they were still considering not conveying into hospital. He must have looked great. He must have had normal vital signs, a normal heart rate and a normal blood pressure. Maybe it was epileptic after all. He didn't really have a postictal phase though. He woke up and felt hungry. Usually people who have a 15-minute seizure wake up and have either Todd's paresis, so they're paralyzed, or they have a low GCS, their conscious level's impaired, or they wake up and they have sort of mood change, behavior change, they're irritable, they have headaches, they're withdrawn. And he didn't have any of that. He came right back online again. And then chapter 2 is in the waiting room where he has a witness episode. And it sounds like it was witnessed by healthcare professionals who saw jerking of the arms again. And how long was the second episode, did you say?
1 minute.
1 minute, and then he's completely alert again afterwards.
So the way that it was described by the wife and in the documentation from the waiting room is that the patient said he felt faint, and he used the words passed out. He had some left arm jerky movements, lasted for around a minute. Nothing else of note. When he woke up, he was okay, just felt, again, not quite himself, just quite weak, but nothing else of note, really.
Okay. So 1 minute and 1 minute of jerking of the limbs, that isn't cardiogenic syncope. They're usually just a few brief tonic jerks they do. So that, to me, points a little bit towards epileptiform, but the lack of the postictal phase is confusing. So those are my two things at the moment. Right now, I'm desperate to examine this patient for any focal neurology, get a baseline ECG, and I would be admitting him 2 episodes of loss of consciousness in 24-hour period. I would be admitting him onto a cardiac monitor to look for any arrhythmias. But at the moment, head, heart, not sure. There's one last thing right at the back of my brain, just itching me a little bit, which is functional. But at the moment, we have to look at the 2 potential organic problems before we wonder if these are dissociative attacks or non-epileptic attacks. So I don't think we're there yet, but it's there at the back.
Okay, yeah, absolutely. I completely thought the same as you, actually, and went down the transient loss of consciousness. Is it cardiac? Is this neurological, or is it something else? So when I saw him at the current stage, when I'd seen him, he'd been in hospital for 24, 36 hours. He'd had no further episodes. He said that he felt weak, but he denied headache. There was no chest pain, no shortness of breath, and no cough. He said he'd had recent antibiotics from his GP for his previous coryzally type infective virally type symptoms, but they've been completed. As I say, he had no past medical history of note. He didn't take any regular medications. There were no allergies. There was no family history of note at all. He did say that around 20 years previously, something similar had happened, and he'd had a vasovagal event, and he'd undergone some investigations that were all normal, but he wasn't able to really recall what they were. On examination, His temperature was 38.3 originally, but when I saw him, it was normal. So he had spiked a bit of a temperature, it was now normal. On I was thinking, is he sweaty? His palms sweaty? They were fine. His pulse was normal. It was 70 beats per minute. There were no extra beats. When I auscultated his heart, there was normal. There was no extra sounds. There were no murmurs. His abdomen was soft and non-tender. His chest was clear. His throat was clear. There was no pedal edema. When I wanted to look at his chest around the rib region where the wife had done the CPR, there was no bruising. He was in no pain. There was nothing suggestive of fractured ribs, which can happen sometimes from CPR, but there was nothing of note like that. When I did ask him to sit to auscultate his lungs, he said that he felt dizzy, but he didn't have any vertigo or tinnitus. He just felt a bit woozy. And his blood pressure, when we checked at this point, was normal. And I did a lying and standing blood pressure, and there was no change at all of noted. Neurological examination was normal. I found no evidence of tongue biting when I had a look at his tongue. Again, whether that's a good sign or not is debatable. But it was essentially a completely normal examination of a patient, and I wasn't worried about anything. What would you do?
Do you have access to EEG?
Sort of. So on the Sunday, no, we didn't, and yes, we could. That could be something we could think about in the week, but not at this point.
Okay. And his blood work was normal?
Completely normal. So he
You saw
had
him 2 days later, no further episodes.
no further episodes, and his blood tests were normal. Full blood count, Usinese, liver function, CRP was normal. There was no sign of any inflammation. He had a venous blood gas on admission into the emergency department. He also had repeat venous blood gas on the medical admissions unit, which was normal. So there was nothing there to suggest that there was any sepsis. His lactate level was normal. He wasn't acidotic or alkalotic. Completely normal gas. He hadn't had a chest x-ray, which was interesting because if he'd had 50 minutes of CPR, would we be thinking about, do we need to look for fractured ribs? Is an x-ray appropriate? Probably not. But interestingly, he had a troponin. And the reason he had a troponin was this a cardiac event? Normally, if somebody's had 15 minutes of CPR, their troponin is pretty high. His troponin was normal. No change.
Okay. I'm just tidying up a few things in this story in my head. So the fever of 38.3, was that immediately on arrival after episode number 2?
It was, absolutely.
Okay.
And since he'd been in hospital, his observations had been normal. No
Yeah.
more
Yeah.
spikes of temperature. Fine. Yeah.
Okay. So it's actually quite common to get a little temperature spike after you have an epileptic event. It's what we used to call a SIRS response. So I wonder if that could be explained by that, if it was an epileptic event that he had, and then he had a little temperature rise after that. Recent antibiotics, can I make those fit in anywhere neatly? There are some antibiotics which cause prolongation of the QTC, which can lead to arrhythmias, such as Torsade, which could cause collapses. I'm thinking of the macrolides like clarithromycin or erythromycin. I'm thinking more rare the quinolones, such as ciprofloxacin. Do we know if he had any of those?
So I asked him what antibiotics he'd had, and his wife showed me a picture of the antibiotic box on the phone. It was amoxicillin, 500 milligrams.
Amox. Pretty
Yeah.
blameless. Okay, so I'm going to tick that off. ECG.
ECG completely normal.
Uh-huh.
And he'd had loads of ECG. It wasn't, he was actually on a monitor. So when I was sitting with him as well, he was on a monitor. We can't get sort of like Holter monitors over the weekend. It's something that we can do in the week. But he was on a persistent monitor, and all of the ECGs that we'd had been normal. So you mentioned the QTC again. Objectively, it was normal. There was no signs of bundle branch block, P wave, QRS. It was all completely fine. It was a beautiful ECG.
Oh, good for him. Okay, so and he had no bruising on his chest. I mean, that speaks a little bit to the efficacy maybe of his
Yeah.
wife's CPR. But what do we expect of people who are not trained? So we need to make a judgment call about, does he go home at this point, or does he need to stay in for further tests? And if so, what would those tests be? And I still haven't put my money on whether I think this is head or heart. And I'm just going through my 2 columns on my little sheet here. Forehead, jerking, prolonged, little temperature spike, had it way in the past. Maybe that was an index presentation. You said 20 years ago you would have been a teenager. Seizure threshold reduced by a recent febrile illness, maybe. Things against that, no post-ictal period. Things for heart, rapid recovery. The wife mistakenly believing he was asystolic. You know, if he was in complete heart block for a while with a heart rate of 25, then that could do that. What else? What else? A very rapid onset and offset. Oh, the prodrome of the vision going funny. That you often feel that when someone is about to have a cardiogenic episode before they go down. And I said the rapid recovery as well. Against heart, normal ECG, no further episodes on telemetry. Okay, so what would I do now? I think for me, I probably will want to see an echo just to look for structural heart, any structural heart abnormalities. For example, has he? I mean, he's got no murmurs, you say, so he shouldn't have severe hokum or something that's completely obliterating his left ventricular outflow tract every now and again. He's got no lying and standing posture, but an echo would be good. Ooh, have I got enough to get an MRI request in? Probably not. No, they wouldn't. They probably wouldn't process that, and he doesn't really need a CT head because I don't think I'm looking for a space-occupying lesion. No headache, no papilledema. So, I think if I was going to bet money on this, I would probably favour some kind of head problem, like epileptiform activity, and I would be thinking about whether a first fit clinic referral on discharge would be a useful thing to do. Very careful safety netting and advising him not to drive, go behind locked doors, take baths until he's seen in the first fit clinic would be, I think, my first instinct. But I'm not completely satisfied with that, and I agree with your resident doctor in that I haven't quite put my finger on a satisfactory outcome yet. How did I do?
Brilliant. Well, I mean, very similar to my thought process, and your plan of first fit clinic, discharging first fit clinic is exactly my plan. That is exactly what I thought. So I spent a very long time with this gentleman and his wife, and spent a long time talking about the history and really what happened in the preceding illness and exactly what happened. You know, was it a faint? Was it a vasovagal? You know, I must have been there for over an hour. And after a very long consultation of history and examination, I explained that I wasn't acutely concerned that there was an acute medical problem that would need admission to hospital for any further. He'd been observed for 24 to 48 hours, no further episodes, investigations, all normal, observations normal. And I said, I'm happy for you to go home. However, because of this seizure-like activity that I think was probably vasovagal in nature, however, I think a first fit clinic could be appropriate and I will arrange this and you will be seen within 7 to 14 days. However, they weren't happy at all. And they said, no, I'm really anxious. I think I've got epilepsy. I think I've got micro brain bleeds. I think I've got a cardiac arrhythmia and a pulmonary embolism. I want you to do an MRI brain. I want a 48-hour ECG. I want the PE investigations and I want an inpatient EEG. And unless you do them, I'm not going home.
Oh dear.
And I said, okay. However, I went through all of those conditions: epilepsy, first fit clinic, micro brain bleeds. I said, I really don't think that's a possibility. He'd actually had a plain CT head in ED as well, which was normal, although that wouldn't pick up on these small brain bleeds. But cardiac arrhythmias, I said, the ECGs are normal. What we can do is arrange a Holter monitor as an outpatient, and there's nothing at all to suggest that you've got a blood clot, given that all of your observations are normal. You've never been hypotensive. You're not hypoxic. Again, very long conversation. And I said, I'm really sorry, but I can't, in all good nature, do these tests because I don't think they're appropriate. And I think it's wrong to do them. We had an incredibly long, very difficult, very challenging conversation. And I said, I really think that home is the best place for you with this safety netting in place. But he refused to go home and he requested a second opinion.
Okay. Sure. I mean, patients can absolutely request a second. I guess coming from the point of view was they are of the belief that he died. He temporarily died and his wife saved his life.
Yeah.
And if you start from that working point, I can see why someone coming in on a Sunday and saying off you go with outpatient tests might feel a bit weird. Even if you try and explain, I appreciate you think you had a cardiac arrest. We are definitely sure you did not.
Mhm.
because they're going to say, well, I know what I saw. I wonder if a useful thing to do would be a neurology opinion in this point, to
Absolutely.
see as the second opinion, just to see whether or not they thought this was
Mhm.
convincing for epileptic or not, and that might go some way towards allaying their concerns about the epilepsy. I mean, they must have been Googling micro brain.
Absolutely.
I'm not
Yeah.
sure what that means, unless they're talking
Yeah.
about sort of
Yeah.
what am I trying to say, amyloidosis, cerebral amyloidosis or something, but that doesn't quite add up. I mean, PE, can PEs present as collapse with loss of consciousness? Yes, but usually with a constellation of other bits and bobs. But in
Mhm.
the absence of pleuritic pain and hypoxia and all that, as you said.
Mm.
Um, so a neurology opinion might be the best way forward. And an echo, I guess, if he didn't have any, I mean, I know he had no troponin rise, but if he didn't have any regional wall motion abnormalities that showed that a big part of his myocardium had died off in a big cardiac arrest, and he didn't have any valvulopathy, then that could be used to sort of make a case. And the other thing I guess to think about is it's a Sunday. I'm assuming you're not going to be at work the next day on the Monday. I don't know how
No.
your rota works, but for me, I've been thinking, well, gosh, I tried. I'll document this very carefully. Tomorrow is a new consultant. I shall hand
Mhm.
over to them, but then they could be the second opinion on this, and
Yeah.
then the patient gets a second opinion and a fresh pair of eyes and see what they make of it.
Mhm. Yeah, absolutely. And you're right in all of those things. What happened to me was it was by now 6 or 7 p.m. on a Sunday night, and I went into the mode of not in front of the patient, but internally, I was like, why aren't they believing me?
Mm,
What is it about me that they will not why aren't I convincing enough? They kept asking for another doctor. What was it about me that wasn't right? Why, I've been a doctor for 20 years. My knowledge is okay, could be better, like all of us. I keep up to date. I do lots of things to help with make sure that I'm always working hard and, nice to patients and communicating well. But they just didn't believe me. And they didn't, it was really interesting because the communication was good. I felt that it wasn't antagonistic at all, but they just didn't believe what I was saying. And they just kept asking for another doctor. Now, I don't know what this was. Was it the way that I was coming across? Was it my gender? Was it how I was dressed? I don't know. It felt quite personal. And maybe that was just the way I was feeling at that time. I don't know. But I did say a few times, and they kept asking for the test. And I said, the type of doctor that I am, I've taken a long history, I've examined you. I genuinely don't think there is anything seriously wrong. I can't request these tests because I think that is wrong, morally
mm.
and ethically wrong, and I can't do them. You may see another doctor and they may also say they're not doing them. More than likely, you'll see another doctor and we'll do all of them. Because by this point, this conversation had been an hour and a half. I could have gone in and said, no problem, we'll do all of these tests and been out of that room in 5 minutes. And I didn't do that. And they requested the second opinion. And I said, that's okay. Obviously, you're not going to go home. We'll see what happens tomorrow. That's okay. But it did really get me thinking, number one, about how I'm seen as a physician, as a consultant, and how patients see me as an individual, but also the necessity of our society today where we need a diagnosis for everything that happens to us. And actually, it took so much of my time to try and explain that it was probably a vasovagal, you've had a recent viral infection, you hadn't eaten, your blood sugar might have been low, rather than it must be one of these serious conditions. And it just made me really question how I practice as a doctor, I guess, And when I came out, I said to the resident doctor, oh God. And he said, Amy, you were in there far too long. And I was like,
Mm.
I just didn't know how to leave. I kept trying to rationalize what I was doing and explain myself, and really challenging. And it was,
I think most doctors, we know that there are two ways to terminate a consultation, and that's either by giving a prescription or ordering a test, because that sort of transaction feels like they're getting value for money, and that, it's a path of least resistance. So fair play for you to not take the path of least resistance and saying I have to stick with the physicianly principles of the right test for the right person for the right reason. It reminds me a lot of conversations we have sometimes about resuscitation and treatments and escalation planning and all that sort of thing, where you have to say, I absolutely get where you're coming from, but I cannot morally or ethically do what you are asking of me because I think it is wrong.
Exactly.
And that's what that reminded me of, that conversation. And
Mm.
boy, that's a hard conversation to have, because often rapport goes west, and then it becomes really challenging, and you sort of starting to have to psych yourself up for every subsequent conversation with them. I'm really interested that you asked, did you say to the resident who was with you, like, oh my gosh, what did you think of that?
Yeah.
Because it's really interesting to get their, not so much feedback, but their perspective on it.
Mm. Yeah, and he said, Amy, you were in there for too long. He said you should have
Yeah.
terminated conversation earlier. And I said, yeah, I
Yeah.
know. And he just said, I agree with you. You know, it's
Mhm.
really difficult and I think you did a good job, but I think you were in there too long. And I was like, okay, I think I was in there too long.
Mhm.
I don't know. I still think about this case quite a lot. It was this year, so it was quite recent. And interestingly, I wasn't in the next day, but I was in on Tuesday, and the first thing I did was look
Of course. Yeah.
what's
Yeah.
going on. He was still in hospital.
Mhm.
And looking, we've got an online system now. So I looked on the notes and he'd been treated for cellulitis. Intravenous
Whoa.
toxicity. I was like, whoa, where's this come from? There was no evidence of cellulitis. There was no evidence of infection, but he'd had blood cultures and his blood cultures had grown a contaminant,
Mm.
but they were treating that as an infection, even though it had been documented by microbiology as a contaminant. I probably think that the treating physician had spent some time and read my notes and gone, this gentleman is not going to go out of hospital until we actually, like you see, undertake a transaction. Now, the consequent people who'd seen him, the 2 or 3 different consultants saw him over the course of a week, didn't request the MRI, the ECGs, the P investigations, or the EEGs because they agreed with me. However, they'd gone down the route of intravenous antibiotics. Neurology did see the gentleman, which was, I think, the right people to see. And I read with interest their notes, and they did come to the same conclusion as me, is that this was probably a vasovagal event, some jerking of the limbs, and that no further investigations were required. However, close monitoring and anything else that was any concerns could represent. And interestingly, the patient was very happy with that, even though the outcome was exactly the same. So I don't know, is that because they'd seen the specialist and I'm not, or is that because it was a different day, different doctor? I don't know, but really interesting. I don't know. It was a really challenging conversation, but also I did a huge amount of self-reflection about what am I doing wrong? What do I do wrong in this consultation?
We did an episode a few episodes ago that's with about this sort of thing when you just cannot reach a concordance with your patient who
Yeah.
wants something.
Mm.
And I people go back and listen to it. I've forgotten what the title of it was, but I got a lot of discussion and
Mm.
people contacted me about that, saying it is probably one of the greatest sources of stress for doctors is when your patient loses faith in you and is asking for things which you cannot supply,
Yeah.
and you have to have that conversation with them. And even more so when the patient puts, draws a line in the sand and says an ultimatum, for example, well, I'm not going till I get,
Yeah.
because I was never taught how to sort of maneuver that sort of
No.
thing. I mean, I'm not going to call security and get the man handed out the building, because unless they were physically threatening me, because I just don't, that's not how I treat patients. And that feels very weird to me.
Mm.
That's just how I've been socialized into the medical profession, and maybe other people would disagree. But in your case, you couldn't say, right, well, if you're not going to go, we'll escort you out, off you trot,
Mm.
because it's just not how the right way of doing things.
No, of
And
course
what we're
not.
really saying when we're saying to patients, you can't have this, I'm not ordering this test or going down this path because you definitely don't have it. We're not saying definitely don't. We're saying I don't have enough of a suspicion. I don't think it justifies it. But we're not saying absolute no. And I think that's why we never hit the nuclear button of what we politely call a facilitated discharge, which is discharge for security, because it's a very, very low probability of that being your diagnosis, but it's too low for us to move in that direction right now. It is often what we're trying to put words around. But it is really tough. I was never taught how to deal
Mm.
with that. I was sort of managed. I learned by own experience and watching other people do it. The resident who was with you would have gained something from that consultation as part of their ongoing
Mm.
training, professional development, by watching it and thinking, okay, so that's what you can do in a situation like that. And maybe I'll try this, or I won't try this moving forward. So I think there's something useful in it for them. And thanks to that resident for giving their support to you by saying, I agree with you. I mean, it sounds silly, but we need that.
Yeah,
Consultants,
yeah, absolutely.
we do need you. Don't think just, oh, well,
Yeah,
I'm an SHO and the consultant knows everything. It does mean a lot to us when you say, oh, I'm on board with that. Actually, that makes a lot of sense. You know, we value your opinion as well. So thank you for offering that. And it's nice that if they're able to do so.
yeah, exactly. And yeah, I think we also need to, you hit it, you were talking about it when we are trained from day one at medical school. Our job is to make diagnoses, do investigations, and manage. Do we? Do we really need to give everybody a diagnosis who comes into hospital? Because that's what people want. Sometimes we end up giving somebody a diagnosis when they don't have anything wrong with them. It's just that we don't know what else to do because they're
Mm.
looking for a diagnosis. But I think we really need to practice a lot more de-diagnosing. I get a lot of people who come into hospital with multiple conditions, and I'm like, I have no idea. I really don't think that you have this, or maybe you don't have it anymore, and actually de-diagnose and take diagnoses away. But that is probably one of the hardest things to do, and it takes a huge amount of time up. So that can be very challenging. But also sometimes we're diagnosing life. Sometimes it's just life, and it is difficult, but sometimes people want a label for that, and maybe we don't have to label everything all the time.
I think another sort of aspect to it is trying to take on shared uncertainty with a patient.
Absolutely.
And it's easier for us, it's not our body.
Yeah.
So it's easier for us to say, I think me and you, we need to understand we don't quite know what these symptoms are. And maybe we'll never know, but maybe they'll come to light down the line when it evolves into something else. But at the moment, we don't know what it is, and we need to sit with that. And some patients can take this. Some patients just, find that quite horrific because that uncertainty, as I say, well, that's easy for you to say, doc, but I'm the one living in fear now.
Exactly.
Can I ever drive my car again? Because
Mm,
I had this collapse. Can I do this? Is it going to happen when I'm carrying my child, when I'm going down the stairs? So it's easy for you to say, but trying to get to a point of shared uncertainty with the patient is a real art. And
mhm,
it behoves us to spend a lot of time explaining how we've got to that point, which again is not something that I was ever didactically taught. I've sort
mm,
of felt my way through to doing.
mm.
But it is really tricky. And I say spend time, although I'm just racking my brains and I cannot think of the last time I spent an hour and a half with one patient.
No, and I think that is the key thing in this. It's time. And we don't have any time anymore. There is not enough time to spend time with a patient. I like to spend time with people. I like to take a history. I like to examine them. I like to explain why I'm doing things and why I'm not doing things. I can't do that in 5 minutes. And I hate the fact that medicine is becoming a bit more transactional. There are so many more patients coming through the doors now that I feel like we have to work quicker. But I feel like by working quicker, I'm not as safe. And a lot of patients are investigated before they've seen a doctor, and they don't even need these tests. So you've got somebody come to hospital, you may already have their bloods, their CT head, their ECGs, when actually when you chat to them, they didn't need any of them. And that also medicalizes the non-medical. There's a lot of things that trouble me at the moment, with the way that we are going with medicine. And I don't know whether that's ever going to change. I think we've gone too far in the direction of too many tests and too many diagnoses, but that's just my personal opinion.
So if you were going to sort of summarize this, you'd say if if your patient is not in agreement with you, the best first strategy is to spend a bit more time
Yeah, absolutely.
and explain what's going
I
on.
understand. Yeah.
Because maybe saying to a patient you could go home in a 5 minute consultation is different to saying you can go home and here's why in an hour. Well, let's
Exactly.
not say an hour and a half, but
Yeah.
in a longer
That was
time.
extreme. Yeah.
Yeah.
Yeah. Yeah.
No.
Yeah. And I think it is all about time and listening. And actually, we forget that part of the healing process when we are with people is feeling heard.
Mhm.
So I know when I've seen my doctor, if I feel heard, that is part of a therapeutic process as
Mhm.
well. I often don't come away with medication or a test, but I feel
Mhm.
heard and I feel validated, and that's all that matters. Again, in this situation, it didn't work, and that's
Mhm.
the opinion was needed, and that's
Mhm.
okay.
There's data for this. I read
Yeah.
a brilliant paper a long time ago, maybe over 10 years ago, saying one of the reasons why complementary therapy,
Mm,
acupuncture,
yeah.
homeopathy, anything, any of that sort of ilk, is that a lot of the therapeutic effect comes from the long consultation times, and actually hearing and having someone say, tell me more about that, tell me more about that. And then 90 minutes have gone. And even if the actual treatment they're offering doesn't have any demonstrable effects, the fact that then they feel they've really poured their heart out and someone has absolutely delineated every tiny aspect of that presenting complaint and its history and time course into infinitesimal detail actually has a really strong therapeutic effect. And the patient comes out saying, wow, that's, they're the first people who've really done a deep dive into that. Those doctors, they don't listen to all this. That's the first practitioner. I'm definitely going to go back there. This is, and I think a lot of the therapy comes from that. But we don't have that. We do not have that that time allowance to do that sort of thing. But it's really interesting. You just reminded me of that now.
And I think the older I get, I want to spend more time with my patients because I feel that that's much more therapeutic than this quick 5-minute triage that doesn't suit me or my personality, whereas it might have done 10, 15 years ago. And I think that's also something that we need to be aware of as clinicians, is that actually we change. I'm a different doctor to I was 5, 10, 15 years ago. And it's about how we adapt our consultation style to that as well, and be aware that we're not going to be the same doctor forever.
Very true.
Yeah. Thank you so much, Ben, for your insight and reflections as ever. Brilliant. Please, please, please rate, review, subscribe to our podcast and share with others, because the more people that listen and the more people that review us, the more people know about the podcast. Massive thank you to everybody out there who's listening. Thanks for listening.
Thank you for having me. See you later.
See you later.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.